Welcome back to another explainer. I'm absolutely thrilled you're here today because we are tackling an absolute heavy hitter in clinical medicine and medical board exams, the varicella zoster virus, or VZV. There is literally nothing I love more than taking a complex, heavily tested topic and breaking it down into a structured, high-yield blueprint. Today we're mastering VZV. We're going to dive deep into the clinical diagnosis, the key differentials, and the strict treatment protocols you absolutely must know for test day. All right, here's our roadmap for conquering this topic today. We'll start with the VZV basics, move into diagnosing primary chickenpox, tackle recognizing herpes zoster, dive into the high-yield clinical complications, and finally wrap up with treatment and prevention protocols. Let's get to it. Kicking things off with Section 1, the VZV basics. So let's get to know the culprit itself. VZV is a double-stranded DNA enveloped herpes virus. And like all herpes viruses, once it's in, it establishes lifelong residency in the body. This creates a really fascinating core challenge. It's one single virus, but it causes two completely distinct clinical syndromes. This is a classic exam trap, guys. When a patient walks through the door, you have to be able to instantly recognize exactly which phase of the virus you're dealing with. Here's how the story goes. The primary infection enters through the respiratory route, giving us what we all know as chickenpox, officially called varicella. But it doesn't just disappear after that. The virus travels and goes dormant or latent right in your dorsal root ganglia. Fast forward years or even decades later, and it can reactivate, traveling back down that nerve to cause herpes zoster, commonly known as shingles. Understanding this pathogenesis duality sets the stage for literally everything else we're about to cover. Moving right along to Section 2, diagnosing primary chickenpox. We typically see primary chickenpox in kids, mostly between the ages of 5 and 9. Now, if you take nothing else away from this section, burn the word polymorphic into your memory. A chickenpox rash develops in crops over 2 to 4 days. It starts on the trunk and face and then spreads peripherally. Because it pops up in these distinct crops, you're going to see lesions in all stages simultaneously. You'll have macular papules, vesicles, and crusted lesions all hanging out right next to each other. That polymorphic presentation is a massive clinical differentiator, especially historically when contrasting it with smallpox, where all the lesions are at the exact same stage at the same time. All right, Section 3, recognizing herpes zoster. So when this latent virus wakes up, it mostly targets older adults, with the incidence steadily peaking in patients over 60. You've got to be able to make an instant visual differential diagnosis between these two rashes. While chickenpox is a widespread polymorphic party, herpes zoster is incredibly restricted. Zoster presents as a unilateral dermatomal vesicular eruption. It strictly respects the midline. Crucially, it's usually preceded by 48 to 72 hours of really severe prodromal pain in that specific dermatome before you even see a rash. Statistically speaking, the thoracic and lumbar dermatomes, specifically T3 to L3, are the most common targets. Now for Section 4, high-yield clinical complications. Pay close attention here, because examiners absolutely love testing complications. Let's break down the primary ones, and notice the contrast between kids and adults. In children, a classic complication is cerebellar ataxia. It usually shows up about 21 days after the rash starts, presents with CSF lymphocytic pleocytosis, and the good news is it's benign and clears up on its own. Now, compare that to adults, and especially pregnant women, where varicella pneumonia is a major threat. It hits hard and fast around day 3 to 5 with nodular infiltrates, and it is incredibly serious. Oh, and keep this in mind. The most common complication overall across all groups, a secondary bacterial superinfection of the skin lesions, typically from Staph aureus or Strep pyogenes. 30%. Just let that sink in. That is a chilling neonatal mortality rate if maternal varicella occurs within a super tight window, 5 days before or 48 hours after delivery. Why? Because the mother hasn't had time to form and pass down transplacental antibodies, and the infant's immune system is basically non-existent. The virus just runs absolutely wild. This is a critical obstetric emergency that requires immediate neonatal VZIG administration. Okay, major exam alert here, and honestly, a real-world lifesaver. Never, ever give aspirin to a child with chickenpox. Aspirin in this setting is absolutely contraindicated because it can trigger Rey syndrome, a life-threatening condition that causes encephalopathy and liver damage. This is a classic rule-out fact that's going to help you instantly eliminate wrong multiple-choice answers on test day. Let's shift gears to zoster complications. It's fascinating how one tiny clinical finding can act as a massive warning siren. Hutchinson's sign is simply the presence of vesicles right on the tip of the nose. So why do we care? Because that specific location indicates involvement of the nasociliary branch of the trigeminal nerve. That means there's an incredibly high risk of zoster ophthalmicus, which can lead to permanent blindness if it's not aggressively treated with antivirals. When you see Hutchinson's sign, it is an immediate urgent ophthalmology referral, no hesitation. Next up is a highly tested eponymous condition, Ramsay-Hunt syndrome. This happens when VZV reactivates specifically in the geniculate ganglion of the facial nerve. The clinical triad you're looking for here is vesicles in the external auditory canal, loss of taste on the anterior two-thirds of the tongue, and an ipsilateral facial palsy. Quick pro tip, do not mix up Hutchinson's sign, which we just talked about, with Hutchinson's teeth. Hutchinson's teeth is a sign of congenital syphilis. Totally different diseases, so don't fall for that trap. Rounding out our zoster complications, we've got to talk about postherpetic neuralgia, or PHN. This is debilitating pain that persists for months after the rash has completely resolved, and it affects over 50% of patients older than 50. The high-yield exam fact here is the treatment. You manage PHN with pain modulators like gabapentin, pregabalin, tricyclic antidepressants, or lidocaine patches. You do not treat it with additional antivirals. Finally, watch out for disseminated zoster, which means more than 20 lesions outside the primary dermatome. That's a massive red flag in immunocompromised patients, particularly those with Hodgkin's lymphoma. And finally, Section 5, Treatment and Prevention Protocols. When we're evaluating treatment regimens, oral antivirals are the absolute go-to for immunocompetent patients. Valacyclovir at 1 gram 3 times a day or famciclovir at 500 milligrams 3 times a day for 7 days are actually preferred over oral acyclovir because they just have vastly superior pharmacokinetics. But if your patient is immunocompromised or if they have disseminated zoster or visceral involvement, you bench the oral meds, you have to bring in the heavy hitter, IV acyclovir at 10 milligrams per kilogram every 8 hours. I really need you to lock in these strict time windows because timing is literally everything when taking clinical exams. To be effective, oral antivirals for adults or adolescents with chickenpox need to be started within 24 hours of rash onset. For shingles, you get a slightly wider window. Start those antivirals within 72 hours of the rash appearing. And for post-exposure prophylaxis, using VZIG in high-risk seronegative folks like pregnant women or neonates, you must administer it within 96 hours, though ideally you want it in within 72. 97.2%. That is the absolutely magnificent efficacy rate of the Shingrix vaccine for preventing shingles. Shingrix is a recombinant subunit vaccine that utilizes the VZV glycoprotein E combined with an adjuvant. It requires a 2-dose series given 2 months apart, and it is heavily preferred for adults 50 and older. It completely wiped the floor with the old Zostavax, which was a live attenuated vaccine that only hovered around a 51% efficacy rate. All right, time for our summary, the grand finale. Let's pull all these threads together. This perfectly captures the duality of the varicella zoster virus for a quick study review. On one side, we have chickenpox, the primary respiratory infection of childhood, rocking that polymorphic rash with complications ranging from benign cerebellar ataxia in kids to severe pneumonia in adults. On the flip side, we have herpes zoster, the reactivation of that latent virus from the dorsal root ganglia. In older adults, it brings that painful unilateral dermatomal rash along with nasty nerve-related complications like postherpetic neuralgia and Ramsay-Hunt syndrome. To wrap up this explainer, I want to leave you with a classic clinical vignette to test your newfound mastery. Imagine a 65-year-old patient presents to your clinic. You observe vesicles in their external auditory canal, and you notice they have an ipsilateral facial droop. Based on everything we've just structured and reviewed, what critical nerve ganglion is currently under attack by the reactivated virus? I'll let you ponder that for a second, but honestly, after today, I know you've got the answer. Keep learning, stay focused, and go conquer those exams.